today's session, Dr. Bande sir, Dr. Kevekar madam, respected senior faculties for today's session, Dr. Katkade sir and Dr. Nilesh Napde sir. I personally feel that Maharashtra State Chapter ISA is honored to have not only senior faculties but also very respectable and senior moderators who are well versed with this kind of topic. We are also lucky to have Dr. Meenakshi Sundaram sir who has joined this webinar, and we are lucky that we have got a third moderator also for this session. For any anesthesiologist, a mishap in the operation theatre is the worst situation in his anesthesia career. And Dr. Katkade sir is going to speak on that topic. And for such mishap to happen, if we take proper precautions like informed consent, then we may not have to face the legal issues. So Dr. Nilesh Napde is going to speak on that topic. So I welcome all the faculties and moderators. I hand over the mic to Dr. Anita madam.
Thank you, Manisha madam. I welcome Dr. Kalpana Kevekar madam, and I am very proud and happy to introduce Dr. Kalpana Kevekar madam. You are welcome, madam.
Thank you. Thank you, Anita.
Actually, Kevekar madam is senior most, and she really doesn't need any introduction to Maharashtra. But as a formality, I will introduce Dr. Kevekar is at present working as a professor and head of the department and of critical care medicine at D.Y. Patil Medical College, Pune, and she has been working at KEM Hospital, Pune, also in the emergency medicine department, and she was the professor and head of the department for many years at BJMC, Pune. And madam is a very well-known teacher, and she is actually a hardcore teacher. She from inside she wants to teach everybody, and she has innumerable many students all over Maharashtra and all over India. And what I like most about madam is her tremendous humanitarian attitude towards her patients, which she has really, though working at public hospital, she has maintained that. And madam is a poet also. So with this very short introduction, I present to you Dr. Kalpana Kevekar.
Thank you, Anita. Thank you very much for that kind introduction. Now I think, Anita, you can proceed with the
Yes.
proceeding. Yeah.
So,
I
sorry,
request
sir.
Sai sir to introduce
Sir,
Dr. Bande.
sorry, sir. Please introduce.
Dr. Bande also does not need any introduction. Yes, sir. Sai sir. Sir, I think you are muted. Sai sir, please.
Sorry, sir. Are you there?
He is there. I think he's
Yeah.
muted.
Now think I'm audible.
Yes.
Good evening to all. It's my pleasure to introduce my friend Dr. Bande. He's known as a Balasaheb Bande, and he is an alumni of for undergraduate to both the postgraduate degrees from BJMC Pune and Pune University. He has done his MD anesthesia. He is one of the unique figure in Maharashtra who has done a MD anesthesia and MD internal medicine both from Pune University. In addition to that, he has done fellowship in ICCM in 2012, and he is a diploma in consumer laws. So you will listen his experts comment today in relation with this law. And he has done also diploma in medical legal studies and from Symbiosis Institute. Now presently he is holding the post as a senior consultant in medicine, anesthesiology and critical care at Noble Hospital, Pune.
There is lot of disturbances. Varsha, please check.
Sorry, sir, please unmute yourself.
Sorry, sir, unmute.
Now am I audible?
Yes, yes, sir.
Okay. He is presently holding the position as a senior consultant in medicine, anesthesia and critical care medicine in Noble Hospital, Pune. He has formerly worked for almost 27 years in KM Hospital, Pune. He is a postgraduate guide and examiner in anesthesiology. He is also postdoctoral guide and examiner for the diploma and fellowships in critical care medicine. He is a peer reviewer of IJCCM SCOA Medicine of Oman. He is secretary Indian College of Critical Care Medicine in 2014 to 16. He was a vice president National Indian Society of Critical Care Medicine 2006 to 8. He was a member and National Governing Council of Indian Society of Anesthesiologists, IJ, National Headquarters 2012 to 15. He is almost member of all the branches of our society, including ISCCM, IMA, API, ISSP, EORA, AOA, and so forth. He is always known national and international faculty. He is a guest speaker on topics in high-risk anesthesia, transplant anesthesia, critical care, ethical and legal issues at various national conferences. Thank you so much, Bala Sahib.
Thank you. So it was too long an introduction. Sorry. I just forwarded the slide which I had. Thank you so much.
Thank you, Sai sir. It's my privilege and I'm to introduce Dr. Sunil Katkade sir. Sir is Chief Medical Director and HOD Anesthesia Department, Sri Mahavir Hospital, Thane. Sir is practicing since 1979. He is ex-honorary assistant professor and anesthesiologist at JJ Hospital and Grand Medical College, Mumbai. Sir, special interest in pediatric anesthesia, cardiac anesthesia, and bariatric anesthesia. Sir is past president of ISA Thane and past chairman Indian Society of Critical Care Medicine, Thane. I salute to Dr. Katkade sir, the visionary who is working
Welcome.
for all the anesthesiologists from Thane and nearby since last 40 years. We are proud of you, sir. His also futuristic vision. His futuristic vision also benefited the anesthesia fraternity, and he is a selfless social worker. Welcome, sir.
Thank you. Thank you.
Now, let me introduce the second speaker for today, Dr. Nilesh Nafde, another personality in our today's speakers, who is having his academic qualification both in anesthesia as well as radiology. So presently he is the president of ISA Konkan as well as governing council member for MSc ISA from ISA Konkan branch. He is currently president of IMA Ratnagiri branch also. He is secretary of AMC Ratnagiri, executive committee member of IMA Maharashtra State. Done many worked very hard and in formation of this radiology association in Ratnagiri, and we know him as a very dynamic person, and we all know him as a person who is giving us a lot of what you call, Nilesh, this his slide presentation is a very unique way he does it, and he has been awarded by IMA National for best effective creative design on digital platform. He is very well utilizing this digital platform and designing. He has been awarded Ganga Hall of Fame award in 2022. And a very good person, very good orator, with very well versed in medical legal aspect also. Welcome, Dr. Nilesh.
Thank you everybody. Thank you, Dr. Samir Sohani, for the kind introduction, and salutations to all the seniors present here. And I hope I am able to give justice to what Dr. Sohani has introduced me as. Thank you.
Welcome, Dr. Nafde, sir. I request Dr. Katkade sir to share his screen. Good evening, Dr. Parak sir. Good evening.
Yeah, can you?
Dr. Parak has also joined the webinar. Sir, good evening. Thank you so much for joining, sir. Thank you so much. Sir, चालू करता please.
Yes,
Sorry
ma'am.
to-
Yes, ma'am.
सगळ्यांनी
Can you hear me? Can you see me? Can you see me?
Mute.
Hello.
Yeah. Can you hear me, madam?
Yes, sir. Yes, sir.
Yes, sir. Yes.
Can you see my slide?
Yes, sir.
Yes, sir.
Yeah. Thank you. Thank you. Good evening, all. I'm thankful to Indian Society of Anesthesia Maharashtra branch. I'm thankful to Dr. Manisha Katikar and team for inviting me such a interesting and heart-burning topic. It's a topic how to handle a family of a patient after mishap in OT. Now, mishap in OT, I would put it three ways: the mishap on operation table, the mishap in a recovery room, and you revive and research the patient and transfer him to your ICU. And what happens? How do you face the relatives and the patient's other family members in ICU? Next, so definition of mishap is an unintentional or unexpected happening that is unfortunately resulting in injury, damage, or loss of life. It may be an operation theater, recovery room. What is the most important thing is an informed consent is a vital for a surgeon anesthetist. For example, we have a very learned speaker who will be talking on consent, but the informed consent and the consent in depth and attending an interview with the patient relatives is a very, very important factor when you are dealing in such situation. Now, please keep in mind, a patient or his relative, he may have muscle power, money power, and political power. So you have to, hence, every person you respect, but trust no one. He may be a potentially dangerous person. Don't underestimate the appearance of the person. They may have got a good contacts, pre-operative and post-mishap. Suddenly, somewhere the news spread, there is a mishap, and social workers or other volunteers, they come in. What happens? What are the reactions of the patients, relatives? The relatives, they may have shock, pain, anger, guilt, or depression. You yourself, as a doctor or a team member, you feel guilty. So patients, relatives, they have no access to the operation theater. Hence, it is a treating doctors and the team. They have to explain what had happened in the operation theater or immediate post-operative. The doctors will have to prove the cause of death. Now, please keep in mind, patients and patient relatives, they also have a rights by the Human Rights Commission. And at the same time, the doctors, the patient relative, doctors also, they have their own rights. Hence, please keep in mind, every person can become arrogant. Apart from that, one should not get worried and fearful, or get worried and under depression, because there's a very interesting judgment which is in the favor of doctors, particularly immediate post-mishap. We all get worried whether there'll be a criminal case or not. Now, it is a very important judgment for doctors. Kindly keep a copy with you. The prima facie of the patient relatives will try to do a police complaint. You are worried whether there will be FIR lodged against you or not. Hence, the private complaint of the complainant will not be evidence in the court. It has to be given by the doctor from the government hospital or the authorities, particularly in your specialty. Hence, if an investing officer, if he calls you to a police station, or he wants your statement, or he wants to book you under rash and negligent action, he has to obtain an independent, competent medical opinion from a doctor of the government solid qualification. A doctor accused of rashness or negligence may not be arrested in a routine manner simply because charge has been levied against him, unless his arrest is necessary for further investigations for collecting evidence. If or the investigation officer feels or satisfied the doctor precedent, again will make a difference. Hence, please do not get worried. You have enough time, and particularly criminal negligence has to be proved by the competent government authority in your specialty. While informing family, this is something, it's a art and science, which may not be given in the books, and every day you have to learn. Kindly use the effective methods of communication. Do not discuss the cost of treatment. For example, something happens in the operation theater and you are trying to revive her, but do not discuss the cost of the treatment. Please try to prove the efficacy of the treatment. Maintain the professional behavior of a doctor and the staff. And last but not least, be sympathetic about morbidity and mortality. You are a part, or you are a family member of the patient. The behavior of the doctor must not be careless. Please do not talk rudely. Please do not discuss in corridor. Other very, very important thing, you may get somewhere unknown calls from some person. Kindly don't attend, because your call may be recorded. Offer every help possible. If your ambulance, hearse, mortuary, loose allegations, do not have loose allegations on the colleagues or the patient relatives to cover up. Do not have any discrepancy on the record. Do not let any member of the hospital staff be under use of some alcohol or abuse. Mortality is a terrible thing for the family. They will feel naturally aggrieved. Feel for the patient and the relatives with a true heart. Suddenly the mob will come in the operation theater. Always talk to maximum 2 or 3 persons in a room whom you have been dealing with. Now there may be crowd waiting outside. Please make sure that security assures outside the discussion with the close relatives in a closed room. Get the other doctors and the staff support anesthesiologists, senior nurse while conveying the bad news. Generally, the bad news is conveyed by the surgeons. Please talk as a team. Explain what happened in details. Explain what was done to save the patient. Try not to respond provocations from the relatives. Please maintain calm and empathy. Listen and show them you heard from them by recapping from their point of view. Empower them by backing. Components of communication. The components of communications are 3: verbal, non-verbal, and paraverbal. Verbal component deals with the component of the message, including selection of the words. How you are going to break the news, please be careful. Kindly rehearse in the mind. Non-verbal component, including body language, posture, gesture, facial expression, spatial distance is also very important. Paraverbal components like tone, pitch, pacing, and the volume of the voice. So, what is exactly these are the skills of the communications, which are verbal, non-verbal, and paraverbal. I request to practice and master these skills when you are having enough time, and rehearse, particularly in mind, how you are going to communicate the news. While communicating, most of us focus on the verbal component. Right? That is only 10% of the message delivered, as a non-verbal and paraverbal components contribute 90% of the total message delivered. Verbal component is important. It includes the information about the nature, course, and the prognosis of the disease. Although also you have to be very options like nature, cost, and yet the investigation and risk benefits of the invasive procedures. Sometimes suddenly the relatives tell you, please disconnect the ventilator. We don't want to torture the patients. You have to explain the risk and benefits. Kindly do not be in a hurry to disconnect the life support because relatives are insisting. Non-verbal components of communication is frequently considered as a less important, and it also has a significant importance on the outcome of the patient satisfaction and the relative satisfaction. Be honest when dealing with the relatives. Most complaints are due to unrealistic expectations of the patient. For example, you are a very high-risk patient coming for a major surgery, and if you try to give a rosy picture and suddenly there is a bad outcome, the patient relatives, they have got an unrealistic expectation. In choice, when given a choice, if you are doing a high risk case, better have a senior colleague or refer to a better colleague. Do not exaggerate your results trying to win over the patient. Primary intention should be to help the patient, not to take the money. While facing a problem, suppose if you are anticipating a problem or your relatives are suddenly rough, they are aggressive, please call a colleague. Fortunately, in Thana, we have got something like a Jan Raksha, where the person can call colleagues or the other people, other doctors, they go and try to help the team. Complications should be discussed beforehand and carefully written down in a consent. If complications have happened, it should be informed to the relatives as possible. And documentation. Documentation is very, very important. It has to be done with proper time and a date. We have discussed arrogant relatives will be a verbal abuse, physical abuse. They may complain to the hospital authorities, legal actions, social media, written and visual media or email, or complain to the medical bodies. Postmortem. This is a very tricky decision. Suggesting or insisting on the postmortem is a must. Relatives may request to cancel the postmortem. Issuing of the death certificate is to be done with the written request and no objection from the relatives. Preferably, if you feel that you are doing a very, let us say you are doing a very senior citizen and a very high risk patient and you are explained death on table, and if you want to give a death certificate, but it should become via police. Don't take it granted, because some other day, the relatives may come in future and ask for the further explanation. It may give the death certificate if you know the cause of the death. It is advisable to suggest postmortem when death is sudden, unexplained, accidental death, when the precise cause of the death is not needed, is needed for the insurance purpose, and a diagnosis how to inform the police. Please inform the police, preferably in writing, and take a written acknowledgement. Nowadays, there is a system of sending an email also. All the medical legal cases, they are supposed to be sent by the MLC also. The information of the telephone is a must. While giving the information on telephone, you must note down the name and the number of the police officer who accepts your phone call. In precautions, ensure, suppose to prevent the precautions, ensure that your working instruments are very well working. For example, your defibrillator is charged, your oxygen cylinders are full, there is enough infrastructure is present, and to deal with the unanticipated and anticipated emergencies. Take services of the medical legal experts, security agencies, and please prove that you have taken the standard care and it was provided. There was no act of negligence and the standard protocols are followed. Documents alone will speak in the court of law. What is not documented will not be proved. Every hospital or a doctor must have a crisis management team or a quick response team. A lack of expert person, suppose if you are dealing or if you don't have a particular super specialist like a cardiologist or some specialist around and you don't take his opinion, it may amount to a professional negligence. In medical records, kindly enter exact time of the events. Don't change the timings, or don't change the other scribble, or don't rewrite. And it, like a changing of tube, changing of electrical tubes, that should be entered in proper documentation. Ensure that you have adequate TV cameras. Lots of time while pre-operative counseling, many hospitals are doing video recording. Sometimes the relatives will try to record your conversation on their own videos. Be careful. Hence, limit the number of visitors by standard. Curve large number of group of visitors in casualty. Emergency department must be manned by immediate polite or staff. So precautions, crowd control is very, very important. Now, if you are trying to withdraw or withholding the life support, it must be done very cautiously. Death certificate must mention immediate cause of death or the other causes of death. We must ensure that the family member gets effect directly and often not indirectly. As an anesthesiologist, as a surgeon, as an intensivist, kindly talk to the relatives. Don't talk via RMOs. We must be always present. And the grief counselor or spiritual guides are also very useful. We have obligation never to leave the families alone. Involve hospital authorities. Sometimes in a hospital, I've seen lots of hospitals, they are employing the bouncers, armed or unarmed. Hospital must take screening of the patient regardless ability to take. These are the important landmark judgment. If as an intensivist, as an anesthesiologist, you are transferring a patient from a nursing home to another ICU setup, doctor must accompany, the anesthetist preferably must accompany patient in an ambulance, not by car or in a car. Non-referral or delay in referral may amount to negligence. And hospitals which declare providing emergency 24 hours by time must have a required instruments and competent staff. Tackling arrogant relatives. Try to fix a difficult person. Accept them as they are. Be present and talk directly to a difficult person. Do encourage difficult persons to express themselves. What the trigger points? The trigger point may be you came late. The trigger point may be you didn't have enough instrument. Watch his body language, what he's talking exactly. In case if there is a mob attack, try to get away safely as early as possible in a secured zone. Call local security, police, management. Keep emergency numbers handy in your telephone. Keep mobile phone. Keep help. Call for the help. If there's a mob attack, suddenly you find there's a violent scheme or there's a suddenly, lots of times the patient may be very popular in locality or he has a big support from a local community. Don't feel ashamed to shout or cry for the help if you feel there's going to be a mob attack. So while transferring the patient, please make sure, is the patient fit to be transferred? Stabilize the condition and transfer the patient for a better treatment. So what is must to inform the police, particularly if you are having a case of suspected homicide or suicidal deaths. Sometimes we had a case which are accidental poisoning or strangulation who was taken for an emergency trauma or death on the operation table, suspected unnatural death, sudden, unexpected, violent, unexpected, instant death after treating the treatment. Somebody has given an antibiotic in the operation theater and there's a reaction, or married ladies within 7 years of marriage. These are also non-anesthetic causes. As an intensivist, as an anesthesiologist, you may be called for this. Please inform the police. In case of death due to negligence in treatment, there are no specific provisions to inform, but order to avoid untoward incidences to inform the police. While informing the police, one thing very, very essential, as a anesthesiologist, as a hospital, as a doctor, treating doctor, please have a cordial relations to the police station. Sometimes police officer may come to you, kindly check my blood pressure. Please offer them the help. That makes your relations better, and you know all the local authorities. And do's and don't with the police. Inform the police when necessary. Cooperate with the police. They will ask you to wait for some statement. They will ask you to wait for explanation of the disease and furnishing copies of the medical records to the relatives, even if it is demanded. Consent of the patient while providing to the police. Follow legal provisions and procedures. So one thing very, very important, don't issue bogus certificates. Certificate issued on request is no defense. Don't neglect the treatment while completing formality, especially serious or emergency situations. This is a very big problem also. Social media, visual media, or sometimes there may be a recording. You have to be very, very careful. Your character assassination can be done and it can be an irreparable damage. So inter-doctor, please see that there is no inter-doctor rivalry. Action possible, maintain the coordination with the colleagues. Show respect for the opinion of the colleagues of the patient who come for the second opinion. don't respond to the social media directly. Get lawyer's help. Sometimes there may be a video which will be uploaded on Facebook. It may be on the YouTube. Take the help of a legal expert. While writing the written answer, use a polite language and be very careful what you are replying on a social media. Be aware, react quickly. Put yourself in the patient relative shoes. Stay cool. When required, stay sorry. Correct misinformation. Recognize and ignore the calls. Let your advocate speak for you. Thank you. Thank you very much. Thank you, madam.
Thank you so much, sir. Thank you for those words of wisdom. And we are really lucky to have you as a speaker because your experience in this field and your experience of working in IMA and on various medical societies has really helped us. And we are really enlightened about this topic. I would like to request our moderators, Dr. Kekar madam and Dr. Bande sir, to express their views on this topic. A very important topic for all the anesthesiologists. Madam, please.
Madam, please.
Yeah, Dr. Katkade has really done full justice to the topic. He has almost touched all the points which are worth mentioning. I would just like to highlight one thing, that sometimes the patient's relatives request, okay, we don't want a post-mortem and we are ready to give in writing. And I have seen number of cases which were referred to our expert committee, where the patient's relatives had given in writing that they don't want a PM, and later on they have gone to police. So always whenever there is a sort of table death or a death immediately after that surgery in the ICU, always I think we should inform the police ourselves, declaring that it is a table death, and we should insist on a post-mortem. So when we are giving a death certificate, we always have to say that the final cause of death, the cause of death, tentative cause of death can be given from the examination. And as Dr. Katkade said, if it is known that the patient was suffering from this disease, we can give a tentative cause of death, but the exact cause of death can always be given after the PM. And when the relatives want the documents, one should never refuse to give the documents. Always give a Xerox copy. Whenever there is an untoward incident in the operation theater, always stay cool. All the members of the treating this thing should come together. They should discuss, and all the notes should be echoing each other. I mean, we have seen papers where the time of cardiac arrest has been quoted differently. The surgeon has quoted some different drugs. So that should never happen. There should be full coordination between the members of the treating committee. And Dr. Katkade has already very strongly emphasized that we have to take the patient to the ICU ourselves, because in Pune itself there was one case where the doctor followed the patient in his own car, and that was not taken lightly by the court of law. So that he has already mentioned. I think he has touched upon almost all the points. But whatever we came across from our experiences that I have just shared, and he very rightly said that verbal and paraverbal and non-verbal, it is extremely important. The patient's relatives must always feel that you are concerned with whatever has happened to the patient, and one must be empathetic, and we have to be very, very careful when we are talking, because they should never, and we should not use the medical jargon, because if we use the medical jargon, then they don't follow that. And second most important thing is we have to talk to all the relatives together, not one after the other. So there should be a conference room like thing or counseling room like thing where we should collect all the relatives and then talk to them. That's all from my side. Thank you.
Thank you, madam.
Thank you, madam.
Sir, Bande sir, please.
Yeah, I think Dr. Katkade has gone through a lot of practical tips, and his lecture was full of tips which you can actually make use of, and that was a very precise kind of discourse which he gave to all of our colleagues and which is very needed. I will just add a few points because what is the possibility of this happening? Is the incidence of such mishaps on the rise? I will say yes. And last meeting also I said we are getting shocks of patients being evaluated, but there could be some hidden morbidities and this rise of diabetes, hypertension, obesity. A lot of hidden comorbidities, especially cardiac and cerebrovascular, are coming up. So appropriate evaluation, I think, goes without saying. This is not the forum to emphasize on that. But I'm saying hidden comorbidities are on rise, and just be careful because they are going to contribute to such mishaps in near future. Secondly, the legal knowledge, basic knowledge of, we all remember that in Pune also we had a case which clauses can be, decided by police because they are in a position. So we must have a legal knowledge or legal advisory to counter their allegation, their plan at that point of time, because we have seen some unforeseen arrests of our colleagues in Pune. And this can happen only when if you have a appropriate senior doctor who knows about law and the legal advisors who are aware of medical legal problems. So there are multiple associations, and I think we all must take like IMA has a cell and then ISA also has a cell. So we must keep in mind and keep all these contacts in our backup so that whenever we need, we should be able to take the advice from them. And obviously when it happens, actually there's a lot of panic, but there's no way but to face it boldly, call your colleagues, and that already has been emphasized by Dr. Katkade. And madam also emphasized on postmortem because there are always requests not to do it. But most of the cases or judgments which came where it was retrospectively evident that had it been done, it would have been better. So I think most of the time you have to go despite the cause of death, because many fora I have heard that if you know the cause of death, give the certificate. But I think in retrospect, it has boomerang later on by some or other way. And to avoid differences is no big bright advice. And I feel we have to be in unison when we discuss with the people. And madam has already emphasized the place and the ambience what it should be, so that we are at a comfortable place. And of course, anticipatory bail is the last one. And I'm sure some legal luminaries in this crowd can discuss about it later on. So that's on from my side. Avinash?
Oh, thank you, sir. Thank you very much.
I just
Thank
want
you
to
very
add
much.
one thing, Avinash.
Yes, madam.
We have to be careful about what the paramedical personnel in the theater, they can be of a nuisance value, because afterward the patients or patients' relatives or the notorious relatives of the patient, they can contact these people and they can get information from them, and that can boomerang on you. So all the theater personnel, not only the treating doctors, but all the theater personnel have to be taken into confidence, and there has to be a unison in, because I've seen that happening, that there is a leakage of information and then that goes against the doctors, and then the case can go on for many years afterwards, because then law also feels and the patient's relatives also feel that we are hiding something, and a story was sort of cooked, and story was told when exactly something different has happened in the OT. So all the paramedical staff also has to be taken into confidence. It is very
Yeah,
important.
there was a question in the chat box
Yes,
regarding cardiac ambulance having appropriate facilities. Should we accompany or should we be following the? But as far as possible, it is better to accompany. And even
yes.
if there is a
Always
preparedness
accompany,
in the
even
cardiac.
if it is a
Always.
See,
Always
I'll tell you one
accompany.
thing. You are the most experienced person. You are an
Yes.
anesthesiologist. You are MD. Very often, these cardiac ambulances, they have a junior RMOs.
Absolutely.
And you don't know what the cardiac ambulance is, But once in a while I walked in a cardiac ambulance, they didn't have particularly some, So it is better you are highly experienced and you know how that particular patient behave. For example, patient may behave for noradrenaline or your vasopressor, how that person is behaving, that patient, or the fluid challenge. So best is anesthesiologist to go with the patient. And when he goes to the next hospital, he can give a better handover position. He can better way to communicate. And always it can be your point of evidence, and it can be your positive point when it comes to your defense. The patient relatives may be complaints. They will be plaintiffs, and you will be defended. And while defending yourself, it can always be your trump card. Now, regarding xeroscopies, Dr. Kelkar madam has mentioned, I suggest that Xerox copies must be numbered. Your pages must have numbers. Yeah, number while original, and kindly give the stamped Xerox copies. They should be signed and stamped. Thanks.
Yes,
Yeah,
yes, thank you, sir.
thank you.
We are, can we take all question and
One
answer later on, sir?
Yes, ma'am.
One more thing
Yeah.
I want to add
Yes,
about the notes. You see, suppose there is a cardiac arrest in the OT. Law does not expect that you go on writing the notes when you're treating the cardiac arrest. So the notes can be written afterwards, taking time to write the notes. It is extremely important because I have seen number of case papers with very gross mistakes while
yes,
writing
yes, yes.
the notes afterwards. So one has to be very, very careful.
Even madam, we can write below in the notes if the patient relatives demand the case paper. You can write there. These notes are incomplete.
No, you can always tell them you can collect the, we are
Yes.
still, and
Yes,
actually the death should never be declared until we are done with our records. And one more
Okay.
important thing, when we are informing the police about the table death, we have to sort of take stock of the situation in the OT. All the ampules should be checked because the whole thing is sealed. And even one single ampule which is post expiry date can become a cause of concern. So we have to make sure that everything, or especially the medicines, are in order when we are informing the police.
No, my point is, madam, in spite of we say that the notes are incomplete, or even saying that the relatives ask for the papers sometimes, and
Yeah,
they
but you
threat
can tell them that you will give the notes tomorrow.
we are not giving the papers.
We
So at
always,
that time, even if we give the
we
papers
should
writing
never
below
refuse.
that these notes are incomplete.
Yeah, that can be done, but actually the notes are
Yes.
supposed to be complete when we hand over the notes. So we can always complete the notes and then only you declare, or then only the people are supposed to know that something is happening.
Yeah, why
No,
what
but
madam says is important because police can confiscate the papers immediately. So what madam said ki before you actually declare most of your work, it is better that it is completed. Patient, we have 72 hours leeway to legally also to give them the Xerox copies of this thing. But police can confiscate your originals, and then you will be completely left with nothing, and that becomes a problem. So it is better that you have backup with you or in some or other form. So you have to be careful about documents.
thank you so much, sir. Thank you. We will continue with the second lecture and then we'll have a discussion at the end. I would request Dr. Nafade sir to share his screen. Okay, sir. Full screen घ्या फक्त.
Yes.
Okay.
Is my screen seen? Am I audible?
Yes.
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 Okay. So my topic is informed consent in anesthesiology. And let's go straight to the topic. Right from the history of consents, the forefathers who have given us down the science of medicine have proscribed informing anything to the patients. Proscribed means discouraged. Hippocrates says, conceal most things from the patient while you are attending to him, reveal nothing of the present or the future to them. This is what our forefathers have said. I'll tell you a brief history of the consents. In 1847, the first ever code of medical ethics published by the American Medical Association did not even mention anything about a doctor-patient interaction. Forget consent. This is as much back as 1847. 50 years later, in 1900, the physicians started obtaining an assent, which means assent is not consent. Assent means agreement of a patient to have or to undergo a medical procedure. This is what started in 1900. Again, 50 years later, approximately in 1957, what happened was the most landmark Martin Salgo case. Always The two words informed consent and Martin Salgo case are go hand in hand. In 1957, I will quickly tell you the story. This patient called Martin Salgo developed weakness in his lower limbs. He went to a doctor, a neurologist. The neurologist suspected aortic or arterial insufficiency, advised Martin Salgo to undergo an aortography or a contrast study of the aorta. He was taken up for the procedure. The aorta was he was injected with a sodium containing radio opaque contrast, some more than 80 ml twice, and the procedure was successfully completed. This procedure was conducted in a radiology suite, and immediately after the procedure, the patient emerged from the procedure with paraplegia. Both his lower limbs weren't moving, and Martin Salgo sued the doctors in the court. The court case was a very, very, very landmark case. And in the case, the courts first entertained, admitted, and accepted the claim of Martin Salgo that he was not told that this procedure of aortography can result in this kind of a damage to his mobility, can cause paraplegia, and even cause death. Not being informed about what can happen was the claim of Martin Salgo, which was upheld by the courts, and hence Martin Salgo case and informed consents go hand in hand. The courts at that time in California, America, for the first time used the terminology of informed consent. Now, what is the concept of consent? We all need to understand today. I will like to give a peace of mind to all the listeners of this talk. What is concept of consent? First, it contests medieval notions of authority. I will explain what I mean. I am a doctor. I am the best well-wisher of this patient. What I do will always be right. What I do will be for the good of the patient. This is a wrong notion of authority over the patient, a wrong notion of authority on the decisions related to the patient's treatment. And this wrong notion of authority is not in tandem with current times. It is medieval in nature. The concept of consent acknowledges that each person is the master of his or her body, and that bestows this knowledge or this acknowledgement of the person being the master of his or her body bestows upon him the right to autonomy. We need to understand by taking a consent, we are giving the patient this autonomy. It empowers the patients with the right of self-determination. It upholds the civil rights of the patient to be privy to the decision on the treatment plan, the probability of success, the probability of failures, and impact of failures, if they ever occur, like in the case of Martin Salgo, if the procedure fails or causes a complication, what can be the impact of those failures? And also, what are the available alternatives to this particular procedure for which the consent is being sought? Now, there are two types of consent. One is implicit. When a patient consents for surgery, there is an implicit consent for anesthesia. If the patient has agreed to undergo surgery, it is needless to say, it is unwarranted to explain, it is not necessary to say separately that the surgery is going to be done under a suitable anesthesia. So you believe that a consent for surgery is a consent for anesthesia. This is what the concept of implicit consent indicates. What is more important is the second type of consent, that is explicit. Here, we need to understand that an explicit consent is categoric written consent for anesthesia with details of that type of anesthesia. And this is what we call as explicit consent. Now, there are so many different terms in consent. I will just run through some of them. What the different components of consent are: informed consent, valid consent, active and passive consent, involuntary consent, blanket consent, implied consent or tacit consent, explicit consent, proxy consent. But out of all this, I have been given 20 minutes to talk only on the topic of informed consent. For this, in these 20 minutes, I have made a presentation of 23 slides, and I intend to dwell on each slide for not more than a minute. For the informed consent, now coming back to our topic of today, that is informed consent. In order for this informed consent to possess social, moral, and medico-legal authority and any credibility at all, the informed consent must fulfill 4 components or 4 prerequisites. First is it has to be the person giving the consent has to have the capacity to consent, which means the patient has to have the ability to understand the diagnosis and the options for the treatment. Lack of this ability or lack of this capacity can be anything. It can be illiteracy, it can be being deaf and dumb, it can be being sub-intelligent, it can be being mentally retarded, it can be being inebriated due to alcohol, but the patient has to be in a capacity to consent, to understand what treatment is being offered, what anesthesia is being given, and for what. If that capacity does not exist, then this cannot be an informed consent. The second prerequisite out of the 4 is voluntariness. Circumstances surrounding the patient should minimize or rather eliminate any undue external influences. No influences, the patient should by his or her own voluntary discretion give the consent and accept the mode of anesthesia adopted or proposed. The patient, the third prerequisite for the being complete informed consent is information. Data for and against a proposed treatment or a proposed mode of anesthesia in a setting where the patient can think and discuss with folks as well as you. Folks means relatives. The patient has to have an opportunity to talk to you, ask you questions, challenge whatever you say, ask for options, think about it, spend time over the decision, discuss with these folks, and then with all this information, voluntariness and capacity, give you what you intend to call as an informed consent. And last component of the 4 is the actual written consent. So all these points which I just mentioned, captured on paper, countersigned by the patient. Friends, we have come a long way from what Hippocrates said. We have come a long way from the Martin Salvo case. And today, here in 2022, where we have a plethora of litigations against doctors, I am going to, in these 20 minutes, give you all the good things about an informed consent, give you the best practices of an informed consent, and try to tell you all that you need to do, that you can do, and you must do in order to avoid litigation or to make yourself safe in the untoward eventuality of a litigation or a complication. But it is not, I have here myself, while in my own practice, I understand that all that I mentioned in today's presentation, like Dr. Katkade sir said, all that whatever he said is ideal and must be practiced. Still, there can be some conditions in which you cannot follow each and every component of the informed consent, but it is my job here today to put forth before you all the nitty-gritties, all the nuances, and all the fine points of what an informed consent implies. Now, coming to end result of an informed consent. Now, if following all these things which I'm going to tell you, what you're going to get is an informed consent. What is the end result of the informed consent? The consent should be an active. What is active? Active means the patient should actively consent. It should be autonomous request by the patient. The consent should always be worded in such a fashion that the patient requests for this sort of an anesthesia to receive a chosen peri-anesthetic course within the advice and guidance of an anesthesiologist. This is the end point of an informed consent. Now, what are the basic principles behind this informed consent? I might be repeating myself in certain parts of whatever I'm going to say, but certain parts will be new. Please try to bear with me. First component of an informed consent is patient autonomy. The patient should be on his own to take the decision. There has to be transparent information. You cannot say that surgery is the only method or general anesthesia is the only anesthesia that you have available and there cannot be any regional anesthesia. This is opacity, and you are trying to force the patient to accept a particular type of anesthesia. So whether regional or regional with general, whatever is the mode of anesthetic management, you have to give a transparent information to the patient as to why, how, and when are you planning to do this. Persuasion. If you feel that the best mode for this particular patient right now is a central neuraxial block, not general anesthesia, you have to have enough words. You have to have a good vocabulary. You have to have only having scientific knowledge and the best intention is not enough in 2022. You need to be persuasive, for which you need to have a good set of words. You have to have an exhaustive dictionary of words to communicate with the patient, and you have to practice persuasion in order to get an informed consent. And the most important is there should be absence of coercion. Persuasion does not mean coercion. I'll tell you a couple of common coercive sentences. If the patient is in denial for undergoing a particular type of anesthesia or a particular type of surgery, then the doctor says, well, my friend, you take your own decision, but you're almost sitting on a time bomb, or you are having a time bomb in your belly, in your abdomen. These are coercive sentences which reflect very badly in the patient's and relatives' mind later on when things go awry. So there are two components of informed consent. First is the good, that is the green color, which is persuasion. What is persuasion? The act of influencing others, that is the patients, through legitimate arguments, which is a justifiable and ethical tool of educating the patients and his or her relatives. This is persuasion. Anything else except this is coercion. I'm going to tell you what is coercion. Coercion is the act of affecting the other's behavior or decision through the use of a credible threat, which is often veiled or hidden or concealed threat. This is coercion. Coercion does not mean putting a gun on the temple of the patient or telling that you quickly give a consent, or else I'll do this, or else I'll discharge. This is a direct threat. But to say that if you don't accept this mode of treatment, then I don't know what will happen tomorrow, or I don't know what will happen after 4 hours, then don't tell me, don't blame me for it. This is all coercive talk, and you are supposed to stay away from coercion, sound only persuasive and compassionate. Medical treatment without consent is battery. Medical treatment without consent is battery. I hope you all know what is battery. Battery is a threat. Battery is a verbal assault. And it also means medical treatment without consent is also an assault. When one consented procedure is underway, please read this sentence carefully. When one consented procedure is underway, performing an unconsented medical intervention can be called medical malpractice. Please try to understand. I am trying to play the devil's advocate. What I mean by devil's advocate, I am trying to tell you what the patient's lawyer is going to claim. If you had received consent for X procedure, and in the midst of X, you started conducting Y procedure without informing, without having a consent, then you have indulged in what is called a medical malpractice. This is what the lawyer of the patient is going to allege, and this is what you will have to face if you do it without having an informed consent. Now, what can be the defense against the liability of what I just said? Now, I just told you that the lawyers are going to say that you have assaulted my patient by doing this without consent, or you were negligent, or you were rash, or you have indulged in malpractice. Now, what are the defenses against this? First, obtain a valid, informed consent from the patient. Second is obtain a consent. If the patient cannot consent, obtain a consent from a legal surrogate. What is a legal surrogate? I'll tell you some examples. A prisoner from the jail of your town, the legal surrogate for that prisoner is the jailer. An inmate of a mental hospital coming to you for some procedure, if not accompanied by relatives, if relatives not traceable, not interested in the patient, so these kind of mental hospital patients are often abandoned, then the medical superintendent of the mental hospital is the legal surrogate. And if you don't have an appropriate consent, if you don't have an informed consent for any reason, document the exception which you have, because of which you don't have an informed consent. I am going to tell you the circumstances in which you can go ahead without an informed consent. Please hold on for a moment. Now here comes the next slide, exemptions from informed consents. What are the exemptions? Emergency cases in which there is an imminent danger to the life, patient is unconscious, and if you don't do a craniotomy on the patient, he is an unknown patient who has been brought from the roadside in a vehicular accident. He is unknown, he has no relatives, you have not been able to, you have informed the police, but you need to immediately do a craniotomy and relieve the ICT, or else there is imminent danger to life. In this case, an informed consent can be stalled or can be kept aside. Incompetence. What is incompetence? Section 92 of the Indian Penal Code has defined what is incompetence of the patient. I'm not talking about the medical incompetence. I'm talking about incompetent patient for giving an informed consent. The 92 of the IPC says an act done in good faith for the benefit of a person without a consent has been defined in section 92. And it also says that this act for the benefit of the patient is allowed because it is impossible for that person to signify consent, or he or she is incapable of giving consent, has no guardian along with him or her, no loco parent, and no legal surrogate. Let me tell you, guardian, loco parent, and legal surrogates are different terms. We need to understand what they are. They are particularly useful only in cases of minors, in cases of people under the influence of intoxicants. It is useful in mentally challenged patients. It is useful in abandoned, unidentified, unknown patients. And it is useful in patients from jail or in the custody of some law enforcing agency. So this was the second exemption, that is patient is incompetent to give consent. Third is incapacity, which is medical incapacity. That is the patient is unconscious or the patient is has a cranial nerve problem. Patient is not able to talk, not able to move his limbs. There is no possibility of capturing the consent on paper. The patient is incapacitated. The patient waivers. The patient in the beginning of the surgery says that I give you a consent for the surgery. And in the middle of the surgery, if you need to transfuse blood, you can go ahead. Any kind of intervention intraoperatively or during the surgery or after the surgery in the intensive care unit while I am on a ventilator and I am unconscious, I give you a consent to do everything that is good for me. I have full faith in you and I waive off the need of a consent as long as I am unconscious. This kind of a patient waiver also can be captured on paper. If the patient is a threat to the society, then the informed consent can be stalled. If there is a judicial order that the court says that you undertake this kind of anesthesia and do this kind of surgery under judicial order without informed consent, the procedure can be taken, can be undertaken. The emergency situations, for example, I'll give you a simple, there are many learned people here on that, they know so many examples, I'll just give one. Suddenly, the anesthesiologist feels that a pulmonary artery catheter is mandatory to monitor a case of intraoperative myocardial ischemia. You may go ahead without having consent for it because of the suddenly developed critical circumstances. Well, if they are satisfactorily documented in the intraoperative notes, that the patient went in shock, that the patient sustained an MI, and the patient had the ECG showed these changes, and we tried to give these drugs. We started oxygen. We started 100% oxygen. We did this, we did that. And these notes, in tandem with your passing of a pulmonary artery catheter, can relieve you of the burden of this kind of not having a consent later. But in all these cases, it is the responsibility of the doctor to balance the principles of autonomy and beneficence. The benefit of your action without a consent, or the benefit of your action in the absence of giving the autonomy to the patient, has to be of that magnitude or that much significance, that much importance, in order to be able to allow you to do the procedure without consent. What are the no's in an informed consent? No abbreviations, no short forms, no amendments, no corrections. Care of the patient, write the consent afresh. No illegibility. Your consent has, if it is handwritten, if your consent is handwritten, it has to be legible, clear, and without any corrections and striking offs. I'll give you an example. Look at this consent. In this consent, the patient Nikhil Tikekar consents for some surgery under spinal anesthesia. And the patient has been informed that because of XYZ reason, he's not been given GA. There will be a corrugated drain, etc. If you just have a cursory look at the consent, reading it is not important. I will show you there are 14 short forms in this consent. Surgery, under SAB, 4 hours, upward arrow ED means increased, RFT means signal functions, increased LFT, GA, NGT, in situ, post-op, ICU, SICU. This is medical jargon. As Dr. Katkade sir said, No medical jargon allowed. Your consents are going to be subject to critical dissection and critical analysis by the judiciary and lawyers and press and everybody. There cannot be any short forms. And in these, there are 14. This is a technically bad consent, which is handwritten. Even I'll show you another. One word of general is cut, then somebody has written spinal, and then and has been striked off. All this looks like afterthought. All this looks like post-surgical correction of pre-surgical notes. This is not withheld as good practice in the core, and this shows you in very bad light. The consent has to look like this: clean, legible, no short forms, no abbreviations, and no rubbing and striking off. There are some myths about consents. Many people believe that consent hona chahiye. Why should there be a consent? Because I'll tell you the myths, 2-3 of them. First, people believe that consents are meant to buy blanket immunity from future litigations. This is a myth. This is a misconception. Please remove it out of your heads. Consents are not meant to give you immunity from litigations. Consent only protects you from litigation due to lack of consent. That's all. The next and also this kind of consent. Look, I consent for any surgery, corrective, resective, or palliative through any approach in any surgical incision for any duration of time under any suitable anesthesia using any anesthetic agent. I consent for any type of infusions or transfusions and intraoperative diagnostic tests. I consent for intraoperative photography, videography, and consent to its use for academic research, commerce, pleasure, or entertainment purposes, and also to its broadcast on social media. I consent for being in isolation post-operatively under monitoring in an intensive care setup on a ventilator support if required. This kind of blanket consents are not allowed in courts of law. So this consent is also born out of this misconception that consent is only to give you immunity. These consents are not good enough in legal scrutiny. Another myth. Once a consent is obtained, doctors are in a safe zone. This is what many people believe. This is also a myth. This is also a misconception. Consent can protect you only from being litigated for non-consented procedures. That's all. Whatever is in the consent, this is a third myth. People believe this. Whatever is in the consent, once a consent is there, it is always valid, binding, and legally permissible. I am legally safe. I have taken a consent. It is binding on the patient. He has given consent, and it is valid only because the patient has signed. A signed consent document can be proven to be invalid in the court for various reasons. Patient can prove that he was under the influence of intoxication. Patient can prove that he was mentally inebriated. Patient can prove that he was a minor and incompetent to give a consent. So it becomes invalid. So you have to be sure that the consent cannot become invalid later. So believe me, these three myths, we have to all understand that consent is not a blanket protection. I will like to give a disclaimer to everybody listening to me here that anesthesiologists should not look at informed consent as an armor against medical malpractice liability. Please read again. It is not an armor which protects you from medical malpractice liability. It only allows you to conduct anesthesia in a certain fashion as pre-declared to the patient. It does not mean that if you indulge in what can be claimed as malpractice, if you indulge in something which can be claimed to be a negligent or rash behavior, you don't get a relief from those liabilities just because you have a consent. Informing the patient about the risks does not eliminate. The sentence is fully loaded, a little complicated to digest. I request with folded hands to all the members listening to me here, please break it up and assimilate it. Informing the patient about the risks does not eliminate the liability of its occurrence. You have told the patient that you can go into hemorrhagic shock. You have an tamponade in your abdomen. I will open your abdomen, and under anesthesia, once the abdomen is open, you can go into shock. And then if he goes into shock, it is your liability to still really revive him and prevent the complications. He has consented to opening the abdomen despite knowing that there is going to be a tamponade. Does not mean that whatever happens out of it, you are immune for those mishaps which happen because you have taken consent. No. So informing the patient about the risk does not eliminate the liability of its occurrence. Medical malpractice liability is based, please understand, medical malpractice liability is based on the theory of negligence and depends mainly on whether standard of care was met and if the failure to meet standards was a proximate cause of injury. Consent nowhere is there in this. So you having a consent does not protect you from medical malpractice liability. So friends, when you take a consent, you need to understand that an ideal informed consent will require to have the following prerequisites. What are they? It has to be educative, as I said, informative, descriptive, accommodative. Accommodative means you allow the patient also to talk, ask you questions, ask you, are you sure this is the only way? Can you not do this? One of my friends underwent the same surgery and he or she had undergone this type of anesthesia. And I don't want that because I feel scared of that needle being stuck into my spine. Any number of questions you have to accommodate, solve their queries, answer their questions, and then go ahead. That is persuasive, informative, educative, descriptive, and accommodative. The consent has to be persuasive. First, consent has to be non-coercive. You should not threaten in a hidden fashion in any way. It has to be written. It cannot be verbal, vocal, recorded. No, it has to be written and countersigned. It has to be valid. The patient has to be a valid consenter, and the consent should stand legal scrutiny in the future. So it has to be valid. It has to be informed, explicit. It cannot be implicit. No informed consent can be implicit. It has to be explicit. Per purpose. I will remind everybody that the Supreme Court had once very badly lashed out at the medical community for giving blanket consents which are pre-printed and taking patient signature at the bottom. The courts had said these kind of pre-printed consents which you believe, the medical fraternity believes to be good enough for each and every patient that comes on your table is wrong, illegal, invalid, and not good practice. There has to be a consent which is per purpose. Per purpose means for this patient of this age, at this time, in this format, under this anesthesia, it should be mentioned in that which is per purpose of that patient. There cannot be a blanket consent which is pre-printed and applicable to all possible patients in your hospital. Supreme Court has given a specific verdict on this. That is why I have included the word per purpose informed consent. So educative, descriptive, accommodative, persuasive, non-coercive, written, valid, informed, explicit, per purpose, and consent with I agree at the bottom and signed by the patient. So friends, compassion, sensitivity, and empathy are our introduction. They are the inseparable parts of our persona. But with time and the medical legal threats, of course, because of medical legal threats also, we are becoming medico-ethical legal robots. Here, I will once again underline the sentence said by my previous learned speaker. He said, at every stage, be the relative of the patient. If you do that, you will always be sound compassionate and look accommodative and persuasive. I have finished my talk. Thank you. Thank you very much.
Thank you so much, Dr. Nafde. It was well illustrative talk, and we could understand meanings of so many things. It was really a nice lecture. We would like to listen from our moderators the words of wisdom. Madam and sir, please.
Dr. Nafde has given a wonderful talk. He has in details talked about the informed consent. I would just like to add one thing that he said about the patient's signature. Along with it, it is required by law. It is always better to have signature of two witnesses, one from the doctor's side and one from the patient's side. You can take the consent of a neighboring patient also. That is okay. And secondly, he very nicely explained about surpassing whatever has been given in the consent, like doing something which is not explained to the patient. There was a medical legal case where a 40-year-old lady, she had a very bad abdomen and lots of adhesions. She had, I'm forgetting the name.
Endometriosis also.
Endometriosis, yeah. And there were multiple adhesions and her oophorectomy was done. And later on, she sued the doctors that she wanted to have a baby and why this was done.
Chandigarh case, it was Chandigarh case.
Yeah, so it is very, very necessary. And secondly, even when we are giving a local anesthesia, it is mandatory that we take in consent that suppose this technique fails, the patient might be subjected to general anesthesia. So because that is one of the
Yes,
possibilities.
very true, very true.
Okay, I think this Nilesh has done the full justice. As usual, his oratory skills force us to understand much more than what he says. The consent has always been a topic of kind of confusion and a lot of, as he quoted, Supreme Court actually practically discarded all the printed forms as if that. NABH and JCI and many other accreditation authorities insist on multiple consents for different purposes. Now they are obviously a legal document, no matter what Supreme Court said, but people keep on debating on implicit versus explicit, printed versus handwritten, electronic versus written, and summary versus blanket. These things will continue for a while, but what one particular point Nilesh emphasized very much was per purpose. And if you mention the per purpose or the emphasis on the purpose is there, and a related complications or related information, so called, which is important for the informed consent is included in that, I think the purpose is done, and that should be the basic part of it, because consent is always challenged. Any case, lawyers, it's a favorite beginning for lawyers to challenge from consent and then move forward with the case, so that we are forced to prove that consent was already there. He knows that consent is there, but often it starts with that. So consent taking should not be taken lightly. As much material you can gather, whether it is written, electronic, whatever, handwritten, it will be good enough for fighting a case in case the situation arises in the court. And I think myths about consent, misconception, and misunderstanding were very well explained and quoted by Dr. Nilesh. And I think there will be many questions from audience. So let's have some discussion on questions.
Yeah, thank you so much, sir. I think before further discussion, we'll deal with the questions from the chat box so that those who have raised these queries, they will get the answer. There is a question regarding how to deal with hypoxic ischemic encephalopathy following cardiac arrest in the immediate post-op period. Anyone, please?
That's how to deal. I think how to deal with the. Please repeat the question, madam.
How to deal with hypoxic ischemic encephalopathy following cardiac arrest in immediate post-op period.
Yeah, so that means your patient's heartbeat is continued. His blood pressure, her patient's blood pressure, his or her blood pressure is well maintained. The patient has got a post-operative encephalopathy. Naturally, you are going to shift the patient to ICU. Your patient will be on ventilator. Patient will undergo typical treatment of a CT scan, MRI, neurophysician's opinion. But best is to document the events of the cardiac arrest, how you have done a resuscitation, and how you have transferred the patient. And one must explain properly. And I think we should not give a very rosy or a very negative picture. Keep the facts very clear. That patient will be observed for some time, and the further care will be taken by a neurophysician or a neurosurgeon. And patient will the further line of action with a certain time. But the relatives may request you, stop the ventilator. We don't want to continue the ventilator. It is a very tricky situation, because one relative may say you stop the ventilator. You don't know, after some days, other relatives, son or daughter, may come and say, why you stop the ventilator? So it is a very, very tricky situation. Hence, continue treatment as our medical science suggests, and follow the team protocol or neurophysician and neurosurgeons protocols.
Sir, by law, are we allowed to stop the ventilator for any patient now?
No.
No.
So,
No.
Yeah.
We are not allowed
Yeah.
to stop the ventilator.
No,
We can
yes.
get a
There
DNR
will be,
consent.
if I can add few points on this, there is
Sure.
going to be some legal aspect to this, because hypoxia, which occurred because of certain reasons. So there will be a lot of legal aspects to this hypoxic encephalopathy. So as Dr. Katkade mentioned and emphasized the therapeutic aspect, including the imaging, the neurological and the critical care aspect of ethical and legal aspects also come in picture, and what led to this hypoxia will also come into discussion, especially when case goes into a litigious kind of consideration. So whatever possible, a lot of patience is needed to manage this patient because they take long time if at all they are going to recover. And it is patience testing for everybody, including intensivists besides the family, because a lot of discussion occurs how long it will take. Is patient going to completely recover or not? Is he going to be vegetative? Are we supposed to disconnect and all that? It's a very big topic. So all the questions which are related to legal and ethical, I think people have to, or the respective friends will have to take advice legal from legal colleagues from there, and also look into the families opinions about right from disconnections to continuation of management for a longer time, and of course includes the economic as well as other social issues.
Anyone to add? Madam, sir, Meenakshi Sundaram, sir, Parikh
We
sir.
cannot, as far as my knowledge goes, we can never set the patient from the ventilator, disconnect the patient from the ventilator.
No, you cannot. We are not allowed.
Yeah, that is out of the question.
So even if the relatives are willing, we are not
No,
supposed
we
to
cannot.
disconnect
We-
the ventilator.
no,
Even if
we
they give
cannot
the
disconnect.
consent, even if they sign, we
No.
are not supposed to disconnect the ventilator. So that should be a very important take-home message.
Madam,
But how to handle the hypoxic ischemic encephalopathy? What about that? The question was that how to handle.
Okay, you're talking about therapeutic this thing. People have been talking about there is not much which can be done because damage has already occurred, and we need to have a repeated neurological assessment.
Counseling, yes.
People have talked about therapeutic hypothermia in immediate
I
this
think
period, but
when the question was asked, it was regarding how to explain to the
How
patient.
to
Yes,
explain.
Yes,
Yes.
yes.
So-
it is about the FIR.
No, actually, it is about how
With
to explain
FIR
to
for
relatives,
the-
how to tackle the relatives when you are having a hypoxic
So how
encephalopathy.
to, yeah. That means the question was mentioning about how to manage, how to talk to the relatives or how to explain to the relatives about the brain hypoxia.
So I think we should involve the specialist and a neuro physician.
Neurologist,
Talk
yeah.
to the patient and let it be evidence based and let it come from the specialist.
no, it's a very difficult issue because we constantly keep on getting such patients, not because of intraoperative arrest, but because of various other reasons.
Yes.
And these hypoxic and patients who are most likely not to recover completely is a big liability to manage as well as to have ethical and these social issues, financial issues to discuss, because they take a long time in the intensive care unit and there's a lot of financial burden on the family.
Yes.
Yes,
So
Meenakshi Sundaram, sir.
there is one.
Sir has
Madam,
raised the hand.
in a nutshell, I want to say it was a very good lecture by both the faculty. And in the consent, he has elaborated so much on the consent. Again, to add that it should be signed by the doctor also, and it should mention the name of the hospital also. These two are needed, but what I want to emphasize, whatever consent we take, if you maintain a friendly attitude, that only is a foolproof protection against the litigation. That is the one point. And regarding this hypoxic ischemic encephalopathy, I want to say the neurogenic insults cause very heavily in the damage suits. The awarding of compensation is very heavy, more than the death. This sort of vegetative state will kill the doctor really. So it is an eye opener, both the lectures, it is good. However much we say, please, we have to maintain a good relationship with the patient that will win the court case, that will avoid litigation. Thank you, Maharashtra.
Thank you,
Okay,
sir. Thank
Okay,
you very much.
Yes,
Sir, if this case is later on, after 1.5 months, if they file a FIR that there's a negligence on the part of the treating doctor, then whether that FIR still holds good, even if it is done at 1.5 months after the
Yes. As
The
far as the
criminal-
criminal proceedings are
criminal-
concerned, it can be any time.
Criminal liabilities have no time span, no time limitation.
okay,
Yes.
okay. Can we move on to the next question?
yes.
Anita, please. Anita.
There is one comment about postmortem, and if relatives don't want the postmortem, let them document so in the presence of police This is a comment by Dr. Pankaj Gupta. So I want to know that whether if the relatives don't want postmortem and then
No,
you documented
That's why,
in presence
that's
of
why
police.
I insisted. That's
Yeah.
why I insisted when I said that
Yeah.
the patients, I have seen patients turning 180 degrees. And there was one case which was referred to us, which was about a cause of death given by an Ayurvedic doctor, when obviously the cause of death was acute myocardial infarction and the cremation was done. He was a Hindu patient. And later on, the patient's another son who flew from Dubai to Pune, he said that PM was not done, and I suspect that some foul play was there. So it is always better to insist on a postmortem.
Yes.
And my contention is, they want or they don't want. Is this
Yes, yes,
all a
sir.
consideration in a postmortem? I don't think
It
they
is
want.
immaterial. It is immaterial. That's why we
Immaterial,
should go ahead.
Yes,
They-
We
yes.
should go ahead and inform the police so that the postmortem is done.
Yes, they don't want does not have any validity at all.
Absolutely.
Yes. So whether they want it or not.
Yes.
The next
We
question
should
is PM mandatory? for
I would like to just ask here to any of the faculties, if the relatives are not willing for postmortem, how to convince them? That is also important, because so many times
We can explain to them that in such a scenario, we are bound by law to go to
Yes.
postmortem. We cannot give a cause of death. I have done it many times in emergency medicine department. Because
Yes.
when the
Madam,
patient
to
is
me, if
absent,
the patient is not willing, how will they go without a death certificate? So you have to issue a death certificate.
Yes,
You
yes,
don't
that's
issue
right.
it.
No, no.
Tell them that I will go behind bars.
When we inform the police,
yeah. So this is the
when we
best
inform the
attitude
police,
that
they don't then ask for not.
Yeah.
See,
Yeah.
very
No problem
diplomatic
for
thing. Very
postmortem.
diplomatic.
When
I
we
think,
inform the police.
See, I would go one step further. You inform the police. Police takes a possession of a body, and
Yes.
you transfer the patient to let them take a body to a local government authority.
Yes.
For example, a civil
Yeah.
surgeon or a medical superintendent or a dean of a medical college, where your notes are evident that this particular patient suffered a myocardial infarction. The civil surgeon can certify that he has a power to certify, looking at the papers, this is a natural cause, and the patient cannot be subjected to postmortem, because this had happened many times in COVID cases. We had, we as a society faced lots of COVID patients who were brought dead to the hospital. And in such scenario, many government authorities have certified deaths, even if without conducting a postmortem.
Dr. Katkade, as far as COVID was concerned, there were some other issues also.
Yes, ma'am. Yes.
But as far as I know, when a patient is brought dead to any government hospital, PM is mandated.
Yes.
Dr. Parak has raised hand and I think he can comment in a.
yes, Bharat sir and then Meenakshi Sundaram sir.
Yes, sir.
No, I just about the postmortem. The best option is to inform the police, hand over the body to the police, and then it will be between the family and the police. Then we are absolved of any responsibility about conducting or not conducting the postmortem. That is one thing. Then about this consent and witness, always insist that person who is coming with the patient, he should sign as a witness, always. Because if the patient is gone, this is the person who will create problem. And if its signatures are there, probably he will think twice before going to the court. And we can always say that this person has signed and he is there. Then one more thing. Still we get patients who cannot sign. And in that case, we are obtaining thumb impression or finger impression. It's very important that we write which side thumb it is, left or right, or whichever finger. That's very important because later on it will be very difficult. Every finger has different impression. So that is to be written. And whenever any relative is signing as a proxy consent or a witness, whatever, capital name in capital should be written. And their relationship, in what capacity he is signing, as a friend or a relative or a guardian or whatever, All these details should be there. Otherwise, it will be very difficult later on after 2 or 3 years in the court to identify this person who has signed it and in what capacity it is signed. So these small things we should take care. Otherwise, that consent will not help us.
Regarding
That's all.
Manisha's question, how to convince the relatives, that is also important because recently I faced that problem. So you can tell about the 3 points are there. One is death certificate, as Avinash clearly mentioned, that has to be from appropriate authority. Not that our certificate is going to be invalid, but it is challengeable by anyone subsequently coming in picture. So we convince on that first point that most legible death certificate will come after postmortem. So there will be no legal confusion in that. Secondly, for insurance companies or insurance claims, the certificate which is best comes after postmortem will not have a legal kind of a controversy later on. That is second point we try to. And third, obviously, is regarding bring in some doctor which is known to the patient or some socio-political person and make them convince the patient, so that because no postmortem is the most of the time emotional kind of a situation there rather than any scientific or a real reason. So I think these 2-3 points can help us to convince people.
Yeah. Thank you so
Even
much,
if we
sir.
can
Sir.
have an exact cause of death,
Madam,
we
Yes.
can
Yes, sir.
treat them.
Madam, this postmortem, I want to make certain things clear. Postmortem can be requested by the doctor or by the patient, but it can be decided only by the police. Even in the police side, postmortem request form is called as inquest, which everyone we know. The inquest should be signed only by sub-inspector of police or inspector of police, who are the investigating authorities. Even the DSP, SP cannot sign that inquest form. The IO should sign the inquest form. So police decides whether postmortem is needed or not. We can only request and we can hand over the case to the police. That is one. Then number two, this as a dean of a medical college, I am saying, because they say the dean can certify or a civil surgeon can certify. If the body is coming to the medical college, by seeing the notes, no one will certify death certificate as it is not valid legally. At that time, the postmortem will be automatically made compulsory. Even then, the medical authorities will request the police to submit the inquest form. So, in COVID situations, the body was handed over without postmortem because there was a separate government order was given for that, as there are a lot of cases. So that cannot be correlated with this. There was a separate order for COVID. Then COVID certificates were given by revenue authorities, like village administrative officers, Tahsildar, those people. Even the doctors have not certified majority of the deaths because so many deaths occurred in the home. So that should not be equated with this. Thank you.
Okay. Sir, I would like to ask you one query regarding your first explanation. You said that police has the authority to order for the PM.
Yes.
But then if the relatives convince the police, or the police gets convinced by the relatives that this patient does not need postmortem, and when it is I would say there is a suspicious death, then what?
No, madam, then we are blessed. If the police says postmortem is not mandated, we are blessed, because the Supreme Court ruling is very clear. The death inside the operation theater occurred within 4 walls. So the cause of death, if it is known to the doctor, then he can certify, or else the postmortem is the final diagnosis. So if the police says postmortem is not needed, we are blessed, because even if we are sued at a later date, we can say the police themselves refuse the postmortem. No police will refuse a postmortem unless or otherwise they are getting everything in written format from the attenders. They will not move the court of law, everything. Then the police will threaten. So if the postmortem is not requested by the police and the relatives convince the police, we are blessed.
No, but
here,
Meenakshi Sundaram.
Okay, sir.
I have got a question. Unless a cause of death is given, how can death certificate be issued? So if we don't give a cause of death and the death certificate, PM becomes mandatory.
That's why, madam, that PM can be requested only by the police. If PM is not done, certificate will not be given. So it is between the police and the relatives. We will not sign the death certificate without knowing the cause of death. That is what is happening most of the times.
patients discharged against medical advice, they die on the way. But the doctor who discharged the patient will not sign the death certificate. Somehow they manage by asking the revenue authorities, or on the way it is death. Somehow they manage. What I am saying, that is not within our purview. Once the police,
I will give you the reason for that, which I have faced many times in emergency medicine department. What has been done, at least in Pune, I know about it, that if a senior citizen dies, even at home, above 65 years of age, then the local political authorities can give, issue the certificate that the patient can be. Yeah.
Revenue authorities, madam.
Yes, yes. Even political leaders, they are giving.
No, that is not possible. Revenue authorities for legally only the revenue authorities. Only routinely VAO certifies that.
And usually
Police
these
bank is
cases
also
is
that.
faced, usually these situations are faced, especially in myocardial infarction cases, because obviously we know that the presentation is like a myocardial infarction, but we cannot give a cause of death until the PM is done. And in that situation, sometimes these local leaders, they are giving these certificates and the problem is solved. But
there
that
have
is
been
outside the purview of today's talk, because we are today talking about OT deaths and deaths related to anesthesia.
But sir, again, I would like to ask you, if the police gives permission that the PM is not mandatory, then who will give the death certificate? Who will issue the death certificate?
Madam, 99.9% police will not refuse postmortem because they will be getting caught in future. 99.9. You are asking is, we cannot discuss it in the open forum. You and I know how these things are settled. How these things are settled. I will inform you once the session is over, as it is recorded. I will tell you how they are solving it. That is the reason I have given you the clue. See, most of the times the road traffic accidents treated in the private hospitals, fearing postmortem, they get a discharge against medical advice. Even after death, some people have taken it like that, but they somehow manage. How they are managing, you and I know. We are not certifying the death. That's all.
Okay.
And I believe that in all the scenarios, your notes have to deny giving the cause of death and insist on a autopsy. Our responsibility too.
Agree.
If we are not giving death certificate, then no problem. Whatever they do is
there have been instances. I will quote one or two instances where police, just to avoid the problem or trouble taking body to the further formalities, have insisted on doctors that head injury hai de do, and subsequently there have been instances where that was challenged. People have certified, the cause of death, that it's a traumatic brain injury, and there have been subsequent complications, infections and shock and whatnot. But in these scenarios, insistence by police need not be, we should not succumb to that pressure. If you feel it is essential for many other reasons, the PM should be done. It is better that body goes for postmortem. Police may insist sometimes that give the certificate, but it's totally up to you to refuse or to give. Most of the times it is better to send the body for postmortem. Everything comes in that, and I think that is better.
Thank you, sir. Thank you.
Okay,
we'll go on to the next question.
one more.
You know what happens? Can I talk?
Sir, sir.
Can I talk?
Yes, sir.
Lots of time, these scenarios, we doctors, 2 or 3 doctors are sitting in a cabin. There are 8 or 10, maybe 20 people. They suddenly enter in a room. There's a pressure and a phone call comes from somebody. I didn't take a certificate. The police inspector also tells you don't take a certificate.
Political person phone se tha
Number 2, very unfortunate scenario. Particularly, somebody asks for a cerebral encephalopathy now if the patient goes in ICU, the bill goes on mounting. Now suddenly they come up. आमचा बिल झाले ते माफ करा. Number, please cancel our bill. Or another very bad scenario is some person comes. Now who will take care of the family? Who will take care of the kids? Kindly give us some compensation. Promise us compensation. We don't want to do anything. Give us a compensation and give us a DC. We'll go home. So in such scenario, we have to be firm that we will not accept, because today you give DC, again tomorrow he will file a case. So in such scenario, one must insist on a postmortem. Number 1, I don't know the exact judgment, but Karnataka High Court has passed a judgment, particularly in obstetric mortality, and they had insisted the post-mortem is a must, and that would have given a further clue what exactly happened. So the decision of a Karnataka High Court is also available on the net. I don't know the exact wording. Hence, it is always better. But very, very unfortunate thing like Dr. Bande, who is a medical administrator, or somebody people face, in the local people come in and they demand the money. Tell the doctor, settle the bill, or tell the somebody XYZ. So I think, such pressures, we should not get pressurized and be firm, and you have to be in a very polite way. You have to send the body for postmortem. As Madam has said that the law doesn't permit you to give it's a very, very important scenario. So, and you can always, suppose if you are an anesthesiologist, you can call a dean of your medical college, or if you can call a local superintendent, or if you want, you can call your local IMA president if you are in a nursing home scenario, or a local Indian Society of Anesthesia executives to come in, and they can explain because they have a fresh mind. And so it's better to go for a postmortem. It is very, very crucial at this stage. Otherwise, sorry. Yeah, sorry.
Yeah, thank you so much, sir, because there are many questions in the chat box. We'll go to, and I think your explanation is answers the question of Dr. Haran Ketkar, sir. That is PM mandatory for a case of maternal mortality. Even you are sure about the cause of death. I think whatever you have answered just now about the Karnataka court case, and that answers that question. Anita madam, we will take the next question, please.
Yes. Another question is, how much say the paramedical persons have in such matters in the court of law? Because we do not have any control on their gossip. Actually,
the legal value of the paramedical people has no standing. Their legal opinion or that cannot be admissible in a legal process. But they leaking information, as Kedkar madam said, they leaking information can be fodder for newspaper, press, the lawyer of the opposite party, and the relatives of the patients to come up with brilliant ideas and further, become aggressive or make the litigation even more sharper against you. That is where Kelkar madam meant that the OT people you should enjoy the confidence of your OT people, and they should not leak information outside for money or to settle scores with you as an employer, etc. Legal.
And secondly, whenever Dr. Nafde, whenever there is a criminal case lodged with the police will interrogate each and every person who has been a witness to the scene, and it is given even to the expert committee. We have seen the narrations of the Aya, the ward boy, the nurse. So that is taken. So it is important. It is important.
My contention is, madam, what the paramedics can say that there was a chaos in the OT. The doctors were running about. They were giving injections. Can they say that adrenaline was not given? Can they say that oxygen?
They may not say that, but they can say this doctor told to another doctor that the heart has stopped, and oh my God, a wrong injection has been given. They can be of a nuisance value.
Tube esophagus मध्ये गेली आणि मग परत काढून ट्रकियामध्ये घातली. Can this be? This comment can be made by the paramedic.
Yes, they can tell that. की अरे ट्यूब तर नाहीच आहे ट्रकियामध्ये असं ते डॉक्टर म्हणाले. So this is taken by the police. तर त्याचं पुढे काय होतं नक्की I haven't seen in the court of law whether those witnesses are produced or not. Because wherever I have gone as expert witness, we were called only as doctors. That time I haven't listened to the whole proceedings of the case.
Anyone can guide about this? Because this is very important.
If whatever statement is given by any paramedic or one who was attending may have some weightage just as a witness, but when it comes to proving that whether the tube was in the esophagus, etc., it will go clearly by the expert and the documentations which have been done, and there can't be any proof that what he's saying. He may be kind of alleging it.
Yes.
Yeah. So it may not be sustainable that way, just because he's saying it is true. I don't think any.
Yes.
Yeah. Any legal system will allow that kind of thing. Then anybody can say anything.
No. I just wanted to say that we have to be very careful about the gossip of the paramedical staff,
नाही,
because that
and-
can ते उचकावू शकतात लोकांना to
हो,
go.
हा, उचकवण्याचीच व्हॅल्यू आहे. But
हा.
let me tell you that whatever they say, criminal lawyers are smart enough. 5 questions they will ask and demolish what that person has said, and he will ask him, you heard this, or what did they say esophagus? Are you sure that it was in the esophagus? Can you vouch that it was in the esophagus, or was somebody asking, is it in the esophagus? They will त्यांना घाम फुटतो and they are not able to answer the questions which can stand judicial scrutiny. I have seen this happening in courts. Criminal lawyers are smart at it.
But they can be used as an eyewitness.
No.
It cannot, it's not easy to prove what they are saying.
Yeah.
No,
There
that,
may
that
be-
matter will be later, but
No, what eyewitness for what?
they can be
Eyewitness
produced
for
as
what?
eyewitness.
Eyewitness for what?
Eyewitness of the scene. What was going in the OT?
No, that's what Nilesh said. If the criminal lawyer defending for the doctor asks certain questions, it is not very easy to answer all the questions which will come there, and that's why it will automatically get into that situation where they will not be able to prove it correctly.
मी criminal lawyers ना investigating officer चे पाय लटपटवताना बघितलेलं आहे. They ask so many counter questions and they try to nullify what the investigating officer has said. तर त्या OT staff आणि paramedics ची काय वर्णी त्या criminal lawyers समोर लागणार? I am telling you that the criminal lawyers are too smart. 4 counter questions and that fellow will retract his statement because he will understand that he is coming in trouble.
Yeah. Thank you so much, sir. Anita, next question, please.
Next, Suchitra Nikam has asked, so is it mandatory to take explicit consent for each and every procedure, or implicit consent stands valid in court of law as far as simple, straightforward procedures are concerned? And it is understood that we need to take informed consent in high-risk cases. And she wants to ask that in high-risk cases, we take informed consent, but in routine cases, can we take implicit consent? Or every time we have to take explicit consent?
What are we discussing? We are discussing a simple case going bad. We are discussing what will happen if a simple case goes awry. So in that situation, you not having taken an informed consent because it is simple is itself, you become culpable for trivializing a surgery and trying to say that it was a straightforward case, so I did not take a consent, or my consent was straightforward. असं म्हणून चालत नाही. Take a consent. At the same time, the culpability and how much deep you go in the case depends on what kind of consent you have taken. That is what, after the Supreme Court judgment that there has to be a per purpose consent, so those pre-printed and those drafted consents have lost their legal value entirely also.
But Nilesh, NABH allows us to use such pre-printed consents.
Because NABH is not a court.
Okay. And
NABH does not give you, NABH does not know what you will do if you are dragged to the courts tomorrow. NABH will not protect you in legal matters. Having NABH will not give you any immunity or cushion. That is why NABH is concerned only with consent taken, non taken. Okay, they just tick boxes. Consent taken, finished. They don't go into the...
But I just want to add something on this, because I am hearing this very often recently, that the informed consent should be individualized. It is impossible. It is impossible to write everything which we have in the printed form. But I think on that form, we can specifically write at the bottom few things which are pertinent to that case.
Yes,
you see, because in the printed form, we are even taking consent of pulmonary embolism, which is a very remote chance.
There are two possibilities. There are two ways of doing this. जसं केळकर मॅडम आता म्हणाल्या, either you add footnotes and additional statements to the pre-printed consent, one, or you don't have pre-printed, press-printed consents. You have consents entered in your PCs and you alter the consent on the computer and then take a print. The computer printed consents can be made individualized, but pre-printed consents are difficult to make individualized. There is very little space available also on that page to add elaborate sentences. You can add 1 or 2 sentences only. So I would recommend strongly computerized consents, computer typed consents, so that you can add karta hai.
But what
somebody had a question in the chat box about the audio visual consent, and actually that is a very valid legal document. If the consent is a video consent, it is a legal document.
A written, valid, informed consent supersedes all other types of consents. I
Written
agree.
means handwritten.
Yes, 100%. No. Handwritten or computerized and signed. And Sakshidar, patient himself.
Then Nilesh, that should always be there. But in addition to that, if there is an audio-visual consent, how much you have counseled the patient, that becomes that can be very nicely explained.
I agree with you, madam, but I have seen some cases in which these consents have gone against the doctor. Current consent darmiyan, patient asks some questions, and those also come on record, and their fears also come on record, and their fears coming true later on becomes counterproductive for us. Because they म्हणाले होते की बीपी कमी झाला तर काय, मला रक्त लागलं तर काय, and you have not addressed that fear of the patient. असं the other lawyers generally encash. त्यामुळे those audio-visual consents are good, but they can be counterproductive and harmful also sometimes.
What about language of the consent? Language, because so many times.
किती प्रकारचे consent घ्यायचे आपण? सर्जरीचे consent,
we
anesthesia
have to take
consent.
separate consent for anesthesia.
We have to.
Anesthesia we have to take. We are concerned about anesthesia.
Manisha, we are bound for anesthesia consent and blood transfusion consent.
Yes. Very true.
Yes,
Nilesh, I
consent.
would like to ask you about the language of the consent, because so many times we get in our part of the Maharashtra, we get many patients who do not understand Marathi, English, Hindi. They speak pure Kannada.
At the bottom, there should be a line. All this has been explained to me in my mother tongue and I have understood all.
Okay.
May I say one thing?
Yes, sir. Sir, please.
The thing is, in our hospital, we are getting many cases from other countries. It's an eye hospital and we get from African countries, Arab countries and all these things. So we have an interpreter who knows that language and English. So always that person is present when we are interacting with that patient. And he is translating between both of us. And his name is always mentioned that this consent and communication was in presence of this person.
Okay.
So this is perfectly okay. Because otherwise you cannot prove. If you don't know patient and your language is different, you just cannot say that everything was explained to the patient, even if you add whatever line.
Yes.
If the languages are different, you have to have some translator in between. Then only you can say that it was given and patient understood everything that I said.
So the interpreter's name and signature is included in the consent. The interpreter has
at the bottom of the consent. At the bottom of the consent.
Yes, along with
special mention.
Am
I correct, madam?
Name and signature.
Yes.
Okay.
Interpreter's name and signature has to be mentioned.
Yes.
Very good. Excellent.
The thing is whether the information was actually given. Whether you have written that it was given is not material. Whether it was actually given and whether it was understood by the person giving the consent, that is material. Not whatever we write or print, that is not material.
Yes. Dr. Nilesh, still the answer is not very clear. Is it mandatory to take explicit consent even for a simple procedure?
Yes, 100%.
Okay, so explicit consent for everything. That should be the take-home message.
It's so time-consuming. How can you? I mean, you need to have different formats for.
Here, Anita, here I would like to say something that in our Pune forum we have discussed so many times. See, Royal College of Anesthesia has got a booklet about the risks involved in various procedures, anesthesia-related procedures. Similarly, our city branches can, come out with certain booklets which can be given to the patient before surgery. The patient can go through them. So we can include all the even remote complications, but the percentages, I mean the frequency with which they occur is also mentioned there. So we are legally safe that the patient has read that. Because it is very difficult to take explicit consent for, suppose a patient is coming for just a removal of a nail after internal fixation, and actually these are the cases, if they develop a complication, these are more problematic than the complicated surgeries and patients with comorbidities, because there the patient's relatives also are expecting that something bad can happen. But if such a complication happens in a normal patient who is otherwise fit, that can create problems. So for that, I very strongly feel that we should have some sort of a booklet where we can distribute it to the patients before coming for surgery. Like I had witnessed it in when my brother-in-law got operated for retinal detachment in a hospital in Bombay. That eye surgeon had given a booklet to read about all the complications, what can go wrong.
And the hospitals which are going for NABH are well equipped, certainly, to have a long list of consents, minor case, major case, supra-major case, with complications, without complications. And then let us presume that there is a minor case, so-called straightforward case, in which you don't foresee the need of any infusion, transfusion, or some invasive monitoring being used. But those circumstances develop intra-op, then you go back outside, explain to the relatives, take the relatives' consent. You mean somebody else also can do it for you, but obtain that consent intraoperatively from the relatives and record it. In case of straightforward cases going back.
Okay. So, Dr. Sachin Sadavarthi has asked, is it necessary to have the consent handwritten by the patient?
No.
Acceptable.
No, not necessary, not essential.
But then handwritten consent carries the same importance that of a computer typed consent?
100%, yes.
Yeah.
Yes,
okay.
it does.
Yeah.
Nilesh, a good example of what you said is a patient going in PPH. All
Yes,
patients don't go in PPH, but then that can be explained to the patient's relatives that this is happening.
Yes, and this was unprecedented, unexpected.
Yes.
Next question.
Next, everybody is just
yeah, there are many comments.
Complimenting the speaker.
Dr. Preeti Shah here. Can I ask a question,
yeah,
madam?
Please.
Yes,
Madam, a patient who has got a diabetic gluteal abscess which is going into the scrotum, post everything has been explained, high risk consent, anesthesia, post-op ICU requirement, everything is explained. The patient goes post-operatively and after 24 hours or say another one more day, patient goes on ventilator and patient dies. Now the cause of death we know is septicemia, diabetes, and patient at the time of explanation of the death of the patient, as usual the social workers and the other elements come. So we, as a doctor, we feel if you want, then we will go for the PM only. We inform the police. Now police is asking us whether you know the cause of death. As a doctor, we said yes. But then in this situation, how to come out and should we insist upon PM or the police will certify and then the body can be handed over with the cause of death?
Can I answer this question?
Yes, ma'am.
For this case, the death has occurred after 48 hours in the ICU. Yes. And the signs of sepsis, all the documentation will be there. The patient most probably will die of a septic shock. So here the cause of death can very well be given. So I don't think in such a case, PM is mandatory. See, whenever the death occurs within the four walls of the theater, OT death is something different. And post-operative death occurring 24 to 48 hours after surgery is a different scenario.
Okay. Thank you.
Madam, the next question is there. In the case of fetal distress for an emergency LSCS, mother does well, but baby had cerebral palsy, CP, that means I think cerebral palsy. Will the anesthesiologist will be held responsible? Mother has done well, a mother is doing well, but baby has problems.
Can I answer?
Yes, sir.
Number one, these facts of the case are not enough. If this case has happened in a metro, in a city, in a municipal corporation area, absence of a neonatologist is none of the anesthesiologist's responsibility. But if the same case has happened in a Mofussil, non-urban, rural setup, anesthesiologist is doubling up as the neonatologist as well. In that case, the anesthesia notes intraoperatively what was done for the baby, whether the baby died immediately at birth, cried immediately at birth, whether oxygen was given, Apgar score, whether the child was cyanotic, apneic, or pale, will all these documented on the records will be able to absolve the anesthesiologist from the liability of CP, which can be due to other causes besides perinatal asphyxia also.
Okay. Another question is there from Dr. Ekta Gupta. How to take consent in a case of emergency LSCS for a patient whose relatives are not present in the hospital? Patient comes for routine ANC checkup and she has to be posted for emergency LSCS.
Patient's consent is paramount. This is an adult patient. Patient is competent, can give a valid consent. Relatives are immaterial and irrelevant. Her consent is enough.
Yes.
Next question. Hello.
Avinash, please go ahead.
Hello.
Yes. Avinash, we can hear you.
Yes. Next question. How much time the anesthesia post-operatively the anesthesiologist is responsible for any death? Hello.
Yes.
How much time post-operatively an anesthesiologist is responsible for death of the patient?
In my opinion, there is no temporal scale at which the anesthesiologist's responsibility ends and the surgeon's begins, or the surgeon's continues but the anesthesiologist ends. The cause
So
of death.
here, a very important message is that we have to, on paper, transfer the patient's care to the surgeon or to the intensivist. Because of which you can.
But still, madam, like for example,
I will suggest, can I talk some? Yeah, now it is not the duration. We are talking of the death, but there are certain issues. For example, there is a post-spinal headache, post-spinal, say, paraplegia, and if the anesthesiologist is visiting the hospital and he doesn't take a post-operative rounds, the anesthesiologist was held guilty. So it is not only pre-operative, it is mandatory for you to visit the patient post-operative also. Particularly, lots of at times anesthesiologist leaves a nursing home. He may go to the nursing home next day. He may go to the nursing home. He doesn't visit the patient. So it is very essential that you document on the court. Second thing, court giving a judiciary judgment and the lawyer framing the team. Sometimes it may be obvious surgical cause, but the anesthesiologist is also called in the court. It causes lots of mental torture because you have to defend why you are not there. Can you hear me?
Yes,
We can hear you.
There is a lot of disturbances, but you please continue.
You know what happens? The criminal, the plaintiff, the patient's advocate, the relative's advocate will always invite as a witness, even if the call is surgical, anesthesiology, paramedics, and the nursing staff. So you have to be really, you have to groom and tell them what they will speak. They have to talk just optimally. So that is very essential. So many times the paramedics are being called even.
Sir, unmute करा तुम्हाला.
Sir, please unmute yourself.
तात्काळे सर स्वतःला अनम्यूट करा. तुमचं म्यूट काढा सर.
We'll take next question. Mr. Shinde has commented that if we are busy in resuscitating and couldn't write notes, how much later we can give the notes, even if we are insisting for notes.
There is a lot of disturbance.
Dr. Madhupati's this is on, so that's why.
Shivraj Madhupati.
Okay. Anita, please read the question again.
The answer is we have 72 hours to submit our notes. In those 72 hours, you can draft the notes. But like Bade sir said, that if the cops confiscate the notes, you can tell the cops that you wait here while I complete the notes, because until now I was resuscitating the patient. I was busy. And let me tell you, resuscitation संपल्या पोलीस आले पेपर कॉन्फिगरेट करायला एवढं कधीच होत नाही. आपल्याला तेवढा वेळ मिळतो त्याच्यानंतर बसून लिहायला. आणि legally we have a cushion of 72 hours in which we can write the notes and then submit them to the cops.
Somebody had asked a question in the chat box. It was seen that if the neonatologist is not there, is it our prime duty as anesthesiologist to resuscitate the baby? Now here I know one case where the anesthesiologist said that it is my duty to look after the mother. So he was not held liable.
Yes,
that is quite logical. That is quite logical,
That's
because if something goes wrong with mother, again he only will be responsible. So on that point, he might get absolved from that particular responsibility, which was actually not his responsibility.
Hello.
But on a humanitarian ground or on a kind of consideration, one can always be part of it. But if something goes wrong, he cannot be primarily held responsible.
On the contrary, if you are resuscitating the baby and something happens to be mother, you will be held negligible, because our primary responsibility is toward the patient, mother. We are concerned with the mother. The child is not our primary responsibility. So nothing should happen to the mother. With that, you can resuscitate the child. There is no problem. One more thing I want to add, not this, about the consent, that refusal of consent should also be documented along with date and time. That is very important, because in many situations, people don't give consent, and after some time, the condition deteriorates. So in that case, if you have not recorded the refusal, then you can be in trouble. So consent and refusal both are equally important.
Yes, it is very true. I agree 100%, especially in the ICU scenario. Yes.
Yes. We'll take the last question in the chat box, which was answered in last program also.
Yes.
But this is an important question. So we will take this last question in the chat box. Is anesthesiologist legally responsible for the mop or the instrument that is left inside the abdomen by the surgeon? Are we supposed to keep an eye on mop or instrument count?
Now, according to the surgical checklist, we are responsible for what is going wrong.
Yeah. Yes. Yeah. This was answered very well last time by Dr. Meenakshi Sundaran sir. Anyone has to comment anything?
So what you will be always cross-examined. Are you hearing me?
Yes, sir. Yes.
See, this is a very. I was invited as a witness by the commissioner, the DCP, to give a statement to whether the surgeon had followed enough surgical precautions or not. So similar thing can happen, that your witness, you will be taken direct or indirect witness to a scenario, and they will try to frame the surgeon depending upon what you say. So it is better, even if you say whether it's liable or not liable, as a team, how you protect, and it is and one number one. Number two, even if there's a mob or some hemorrhage, the criminals, the advocate of the patient relative will always put charges against the team. The first person will be surgeon, second will be anesthesiologist, third will be nursing home staff, fourth will be nursing home, fifth will be, so it will be entire team will be put as a team, and all the charges will be put against the team. So you have to defend, you are given a proper anesthesia. Hence, it is up to the court what to say. Correct, sir,
If
you want to say something?
If you give the adverse opinion, the criminal lawyer defending the surgeon only cross you and ask difficult questions which you will not be able to answer.
No, but Dr.
So it is better that you remain in full tune.
According to the surgical checklist, whatever has been laid down, the principles, all the members in the OT are responsible to, when that call is given, the count of this mops, the count of instruments, everybody who is present is responsible for whatever is happening.
Madam, here I would like to ask you one question. The call is always given by the sister, who is the main sister in the OT, is assisting the surgeon, that the mop count is okay, the instruments counted are okay. But then we, as an anesthesiologist, do not count the exact mops that has been used in the surgery. So
But
I
you
think
can
that
at least say this: the surgical checklist was followed.
Yes.
yeah. Now the surgical checklist, and
was
suppose
followed, yes.
it was followed. But suppose then you
Then
after some days,
then the sister will be liable because she has given a wrong count,
okay,
not you.
okay. So even if the mop is found later on, then that
Then
sister
you
will
are
be,
yes.
yeah, not even the surgeon also.
That I don't know.
Actually, the
Dr. Manisha,
responsibility lies on the surgeon because surgeon has employed the sister.
Dr. Manisha, just I have a comment on this.
Sir, please.
This surgical safety checklist, what Madam Kelkar Madam say, absolutely right. It is a mandatory for the team. The team leader is the even surgeon that moment of time, unless until timeout is done and
Yes.
everybody confirms it. It is the responsibility of the anesthetist also to to confirm the timeout. So the total team is responsible. If something is remaining in the abdomen, we are also held responsible in that case. There is no excuse for that.
So
I beg to differ on this point because surgical techniques and everything are getting more and more complicated, and anesthesiologist is not expected to know everything about those things. So whatever his surgeon is supposed to do, he is supposed to do. What am I, as an anesthetist, I am supposed to do? I can't hold a surgeon responsible for that he did not remind me or something. So I think the courts also will be very prudent in this aspect, and they will not hold other people responsible for that. Although we are
Dr.
working as a
Parekh,
team. Yeah.
Dr. Parekh, we know that you have a vast knowledge of the subject, but there have been 2 cases in Maharashtra where a wrong side was operated when the anesthesiologist was held responsible.
Even for
Wrong
mop also.
side, wrong eye.
Yeah. Madam, in that case, the case I know the registration was kept on suspension for some time in Maharashtra.
Yeah.
It is taken as a teamwork.
It is teamwork. It is mandatory.
Yes.
No, at least recent law, what it is saying.
If we go by that theory, somewhere you will have to draw a line because you can't have knowledge of entire procedure that surgeon is doing and developments and all.
Sir, that's
So
why
you
only the
cannot
surgical
just
checklist. It is not details. Surgical checklists are very prominent points.
checklist, of course, I agree with the checklist is okay. That timeout is done, and timeout in our hospital is done at various stages. We have multiple timeouts because when the patient is brought to the theater, it is timeout. When before inducing, it is a timeout. Before starting surgery, again there is a timeout, so that nothing happens wrong. That is okay, timeout. But then whether the mop is left or it is not counted or any other surgical thing if surgeon has done or left or something, who knows? We don't know all those things. So there has to be drawn some line where my responsibility. Beg pardon?
Vice versa is also true. There are many cases where the anesthesia problem was there, but even surgical colleague was also held because it is teamwork.
See, in the court, there are so many things that how the things are put before the judge, that also matters. And then the lawyer and everything. So you can't go by all those things. And plus, one judgment, if it is challenged in the higher court, maybe it was not challenged. If you feel something wrongly has been decided against you, you can challenge the higher court. Then probably you know what happens. And you accept the judgment as it is, probably because it doesn't hold the logic that when there are different specialists and different fields, and you hold somebody responsible for somebody else's thing, which you are not supposed to know.
Dr. Vande, sir, can I?
Yeah. The checklists are done for safety purpose. I don't think there is a legal mandation about this checklist where everybody is responsible. When courts have analyzed the situation, depending on how it was defended and put up across the court, probably there will be people who will be asked for absolution from that. Okay, I'm not responsible for this. So it may not hold a legal scrutiny, and many people have withdrawn, kind of a discharge from the cases because that was not their part. As a team, that's fine. The spirit remains. There shouldn't be differences. There should be consensus. But when it comes to a criminal liability, it may happen that one particular person will ask for discharge, and there have been instances where people had no concern and they were discharged. So criminal liability is something very different than compensation. Compensation, there are many examples where it was combined and differentially distributed amongst the team and paid. But it may not happen for a criminal liability.
Dr. Bande, shall
Yeah.
I?
Yes,
Yeah,
sir.
please.
Sir, instead of further discussion on this, I want to make a comment. So far, for keeping a mop inside the abdomen, no anesthetist was held responsible by the court. That is the inference I want to so far. Then operating on the wrong side, anesthetist is responsible because they have taken it as abetting the crime. We have to check the side. But keeping the mop, see, anyway, even if we are sued as a team, what I want to say, see, we are monitoring the blood pressure reduction, we will be injecting some drugs, how we can monitor the sponge count and also. Even then, in that also, last time also I mentioned, if the staff nurse is qualified, she is also severally responsible. But if she is not qualified, only the surgeon and the hospital authority is responsible. So far, instead of we making our own comment, whether we are responsible, a surgeon is responsible, so far, the court has not punished any anesthesiologist for keeping a mop or a foreign object like a scissors, artery forceps inside the abdomen. So anesthetists can take that point. So far, no one was there. So we need not waste time in that discussion. Thank you.
Thank you so much, sir. Any more questions? I don't think there are any questions also. It's 9:20.
Yeah.
It was a excellent discussion, and I must say it was an interactive session with all the seniors giving their expert opinions. And we are really thankful for such a long session for almost 2.5 hours. Avinash, sir?
Congratulations to everybody, all moderators, organizers, speakers, everyone. It was really excellent to interact.
Yes.
And I also enjoyed it a lot. Thank you very much.
Madam,
Thank you.
madam,
Thank you.
one
Thank you.
last question, madam.
Hello.
Yes.
Yeah, one
Yes.
last question regarding the insurance companies paying for the consumer forum. Are they really honest in paying the compensation, sir? If you are insured, now that the anesthesia team is being anesthetist insured by this Cover You, ICICI, so many companies have come up, and they are even promising us for out of the court settlement also. Have you encountered or come across any cases where out of the court settlement, or have they come forward for paying the compensation when the consumer court finds guilty?
I have no personal case.
Parag sir will comment on this.
No, see, one thing is that insurance company itself can be implicated as a party. That is one thing. Second thing, if they want out of court settlement and the insurance company is willing to pay, what do we lose? We should accept that. And if whenever a case is filed and if we are insured, we should implicate the insurance company in the beginning itself as a party.
Yeah.
Okay.
Okay. I just last point which I
Thank you very
forgot.
much.
Last point which I forgot to mention. One second. I'll just close sentence. When you are going out of station, please avoid a temptation of giving anesthesia on the last day. That is something which is very tempting, and this has put people or even surgeons in trouble. They operate, and if they go out on third or fourth day and there is a complication, it is always also when you're anesthetizing, when you're operating, you make sure that particular day, at least 24 hours, you are in touch. Sorry for the.
Yeah, that reminds me another one warning that reminds me of another warning that if you are found online during the intraoperative period, it can go against you because there will be enough proof that you are found online. This has happened in one of the cases discussions. So be careful about handling WhatsApp, Facebook, Instagram while you are actually supposed to be doing the patient monitoring and doing the professional job. This has to be noted.
These are the two excellent take-home messages today. Dr. Sunil and Dr. Balasaheb. These are the two excellent messages to all the senior, junior anesthetists.
Thank you so much.
Yes.
Dr. Katkade,
Yes,
there
thank
was
you,
a case in Ratnagiri, a cesarean delivery.
I know.
Yes.
Yes, I know. It is very, I mean, it has come, and I mean, I think, if you can Google, you find the judgments, and yes. Thank you.
Yes, absolutely.
Yes, sir. Yes, yes. Thank you. Thank you very much. It was a very wonderful session today. I thank to Dr. Katkade sir and Dr. Nilesh Navade for excellent presentation. I also thank Dr. Kalpana Kelkar madam, Dr. Bande sir for perfect moderation, and Dr. Meenakshi Sundaram sir and Dr. Parag sir for their valuable inputs in this session. Thanks to all who participated in this session, and I declare that this meeting is over. Thank you very much, and
Thank you.
good night.
Thank you.
Thank you. Thank you. Thank you.
Good
Thank you
night.
so
Good
much.
night. Good night. Good night.
Avinash sir, stop the recording.
Varsha, please stop the recording. Okay.
Thank you.
Yes.
It was really
Yes.
wonderful, sir. It was an exhaustive session for almost 2.5 hours, but almost around 70 people were still there who were attending this session. So thank you
Yes.
so much. Yeah, thank you so much.
It was.
Meenakshi Sundaram
It
sir,
was
thank you
full
so
in
much.
first 15 minutes.
Thank you. Pleasure is mine.
Thank you.
Thank you, Meenakshi Sundaram sir.
Lot of learnings
Thank you.
for all of us. Yeah. I would like to take the permission whether should we post this on YouTube, because people will be asking us.
Yes, most
I
certainly.
think the medical legal session should not be put on the YouTube, because there are some point that the lawyers can take from us.
Yeah, I think the patient.
Madam,
Hello.
Suggest.
Madam, now the recording is over. Recording is over.
Yes,
Recording is over.
Yes,
Recording is stopped.
I want to say the speakers and also the people who are making the comments, they should avoid the word politicians, because we want to equate politician as a local thug. Every time we say the local politician will create a problem, instead we can say local bigwig can create a problem. Some we can, because every time we say politicians, they will come. Local politician will call you. Every time we label politician as a rowdy element, that can be avoided in the open forums. And how these people are managing, madam, they will take the patient, even though it is a road traffic accident with multiple injuries, fearing postmortem, then they will ask the VAO to certify that it is a natural cause. They will totally forget. Police also cooperate, because if they register the case, police has so many problems like FIR, daily the calendar list, so many issues. So they also cooperate. That's how it goes routinely. Even the ICU managing people should know that they should send the patient against medical advice. Then they will get certificate from somewhere. Everything is done with the mutual consent only. If they agitate, then it is a problem. Everything goes to the mutual, because 8 years I have practiced ICU. All the time, the private hospital, the patients, they will refuse postmortem. Then they will say, then to keep me on the safer side, I will refer the patient to Chennai. From Tanjavur, I will refer the patient to Chennai. So my responsibility is absolved on that particular time. Some 3 people only agitated again. They came to me and they asked for a death certificate, but I refused. They will say they have transferred the patient to Chennai. On the way the patient expired, somehow they will manage the certificate. Another problem comes in the ambulance. If the patient is dead, no one can certify, because only nurse, paramedical people is there. There is no doctor. That is a problem. Somehow, then too much of legality will also kill us. Too much of legality. If suppose the police says, sir, I will take care, you please oblige, then you have to analyze the situation and you have to adjust with the police also. If you say, no, I will not accept, I will go as per rule, then police has so many ways of looking for rules. That is also a problem. That is a practical suggestion we cannot discuss legally. See, you have to cooperate with the police also, because the local police can drag us in any case, even if not that particular case. Anyway, keep a good rapport with the police and the lawyers. That will help us.
Sir, sorry, I was just out, but you know something. You mentioned about the, what do you say? What is the word to be used for the
big wigs?
That is big wigs. I said Local, we are local big. Instead of saying the local politicians, they call us. Every time we say, sir.
No, sir, 1 minute. So the same, they have a better and bigger contacts and bigger spine than us.
Yes, sure.
Now, for example, your ward boy, one who is working here, maybe a local, his friends, you don't know who is outside. And it may happen that ward boy has been given job by the same person.
True, sir. True.
Not only that, they know everything. What time you enter, what time you leave, what are your habits, what are your weaknesses. So they are very well informed. In fact, now the place where I practice, 2 buildings away from me is a chief minister's residence. 2 buildings away. So every person who comes to hospital, I unka aadmi hu. So and he knows everything. He knows everything because he has the people. So, sorry for because since the recording is not there, thanks for this advice. But unfortunately, every person see, this is what particularly when the elections, everything is going well here and it's okay. I mean, but that's a very good advice you are giving.
No, sir, we're not supposed to wound anyone, sir. When you are
1 minute,
speaking in the forum,
Varsha,
anyone.
can you hear me?
Palatable way of putting it. If you say local people, you are talking about politics.
Hello, Varsha.
Talking from experience, sir. Both are too good.
Ask her to stop the live streaming on YouTube.
Okay, we'll stop that. I think we'll have another session, unofficial session for this.
No, medical legal will never end, sir, because we are facing a lot of problems. It will never, but both are too good. Your experience and expertise was well known. The way in which you have put it, one is very cool and another one is very vigorous.
Perfect.
Age difference, that
age perfect, sir.
Age difference was there. One is so cool.
Age difference.
Another one was very hot.
We need that too. We need contrast in life.
Yeah, that maturity. Sir was talking with maturity. He was talking with emotion. Anyway, we are consenting that both the lectures are too good.
Yes, sir.
Yeah. Excellent.
Yeah.
Thank you.
Lovely
We'll
talk.
end the session here. We'll end the session. We'll meet again.
What I request, let us not upload on YouTube because somebody has suggested.
Yeah.
It can be used as a trump card and as sir has suggested, we might have used some news terminology.
Yeah.
Yes.
Neither will we upload it on YouTube, neither we will share it to anyone. That's what I would say.
Yes.
We would not share it to even any other anesthesiologist also.
Yeah.
Even on the anesthesia group.
आपण tips मिळतील त्यांनाच.
नाही म्हणूनच म्हटलं की even on anesthesia groups also we will not share it so that it will not get circulated. Yeah. Thank you so much. Thank you so much.
Bye. Well done.
Let's meet on 26th again with some other interesting session. 26th of this month.
Bye. Ciao.
Yeah.
Okay, thank you.
Okay.
Thank you.
Thank you, everybody. Good night.
Good night.
Good night. Bye bye.